Thank you so much for letting me come and talk today. My name is Misty Todd. I am a family physician who practices obstetrics in Cole Camp, Missouri. So we've heard a lot about access to rural care, and I and my husband, who is also a family physician who does not do obstetric care but is the nursing home director for 2 nursing homes in our county, in Benton County, we have dedicated our lives to increasing access to physician-led healthcare in rural Missouri. I grew up in Northeast Missouri and fell in love with a guy in Sedalia and ended up saying Sedalia's too big, and we both found small communities to practice. And in doing that, along the way at my training at the University of Missouri, became involved in increasing access to care, and actually currently am the first rural training track residency director for physicians training to be family medicine physicians in the state of Missouri. Doing that, I also am in collaborative practice with a nurse practitioner in my clinic, and she is wonderful, and she is an essential part of our healthcare team. But today, I'm here on behalf of the Missouri Academy of Family Physicians to once again repeat that we do believe in physician-led healthcare. The first opponent testified much of the data and did a great job of doing that, and you're currently getting a packet with very similar statistics, footnotes, all of the links, and I won't bore you with that. But I do want to talk about how collaborative practice works in my mind, in my clinic, and how it actually increases access to care, specific to a patient last week. My nurse practitioner, she worked as an ICU nurse for multiple years, went to nurse practitioner school, and has come out and has worked in our clinic for 5 years. She sees patients when I'm not available, and she has her own patient panel. One of her own patients came in and said, I have some postmenopausal bleeding, and for many of the healthcare workers in the audience, postmenopausal bleeding is cancer until proven otherwise. And how do we prove that? We do an endometrial biopsy. So I'm on my part of the clinic, she's on her part of the clinic, and comes and says, I'm not sure, do I need an ultrasound, do I need a biopsy, what do I need to do? If I need to do it, I can't do it. I actually stop my clinic, I go over and do the biopsy for the patient. So the patient has less visits, the time from symptom to tissue diagnosis is decreased. She has less copays because less clinic visits, and is hopefully on her way to gyne-oncology wherever that may be. And so that's what collaborative practice looks like in my life. I also want to speak to, increasing access to healthcare. So I'm there training physicians, and there are those of us out there that want to take care of patients in rural Missouri. We're passionate about it. We speak farm, we speak cattle, but we also speak healthcare, and we speak medicine, and we're trained in evidence-based medicine. We want the best for our patients, and we believe that as the rural training track produces more physicians, we'll be able to increase more collaborative physicians. But my husband and I are in 2 separate clinics. We started our practices there right as COVID was going, and we were overworked, and we needed more help. And we looked to have collaborative mid-levels, whereas it be a NP or a PA. And we actually put out job openings in January of 2022, and we did not hire anyone until September of this year, of 2022, and actually could not start practice with her until December of this last year. We had 10 applicants over 9 months. We interviewed 3 of those, and it wasn't because the applicants weren't kind that we didn't choose them. It wasn't because they didn't have degrees, because they did have master's levels degrees in advanced practice nursing. It's because that the skills and the experiences they had in school did not prepare them for medicine in rural America. When we asked things like, tell me about the procedures you've done, we leave it a little bit open, and one of the applicants was very excited. She was like, I'm really good at injections. And so we're like, yeah, tell us about the injections you do. Like, We do inpatient and outpatient medicine as family physicians there. We do shoulders, knees, hips, fingers, trigger fingers, lots of things because getting to orthopedics is difficult. And she is very sincere in saying, I can give flu shots and I can give MMR vaccines and I can give Hep B vaccines, when really her version of injections was just immunizations. And when we ask her specifically, what is your training on knee injections or what is your training on shoulder injections, she'd never had that done or been taught. And so the collaboration agreement allows them to work under physicians to learn those skills that they don't get in school. In our role practice, we serve as a, catch-all in ER and, lots of farm injuries. Farmers, my dad included, are one of the tough types, They will have, smash their fingers in a post-hole driver and it's hanging on by some tissue and they won't go in. And so we always ask, what are you comfortable doing as far as suturing? Can you stop the bleed? And they're like, that hasn't been our experience in the people that we interviewed. They weren't familiar with stopping the bleed or, suturing on someone who was awake and actively bleeding. And that is essential to our everyday practice in rural Missouri. So I'm getting the time, and I could go on as most people can, as we're all very passionate about this, but I'll open it up to questions.
Representative Fogel.
Thank you to inquire.
Go ahead.
I'm going to ask you some of the same questions. I don't know if you heard me ask of your colleague earlier, but a lot of the testimony I think we're hearing today is more specific to individual practices preferences, not necessarily related to the state statute. So going back to what the language currently reads, a APRN has to submit 10% of their charts to be reviewed every 2 weeks. So my question, again, is kind of surrounding that, in that if we have these grave concerns that APRNs aren't doing what a physician would want them to do, I have yet to hear testimony from anybody that we should be increasing the number of charts that need to be reviewed or decreasing the amount of time that a physician has to review those charts. And it would seem like in the medical field that if you're not touching that chart for 2 weeks, the damage that you were going to do, you would have already would have already done. So I guess I would like to hear your thoughts surrounding that. And if we really do have these concerns, it would seem that there'd be an effort to strengthen the language. And I have yet to have anyone approach me about that, but I've had a lot of people approach me about the opposite. So I'd like to hear your thoughts on that.
Sure. I think in my specific case, and I can speak for my husband's, as sometimes wives like to do that. But in my collaborative practice, when I started, I reviewed every one of her notes for the first 3 months and really built that trust relationship. She had been there before I did, and I was the newcomer. However, pointing out things like evidence medicine, we don't need a pap smear every year anymore. Pointing out that, colon cancer screenings have changed. Everyone doesn't need a thyroid screen every year. Those things we talked about as those were coming. So it didn't seem as lumpy at the end of 2 weeks, where it's like, here's all of these things I saw that were wrong. It's generally creating a relationship and changing practice styles over time. In the question of the damage is already done, the way my collaborative practice works is ideal. I get calls when I'm on nursing home rounds, when I'm doing a delivery. Hey, I've got someone here with this. I'm concerned for this. What should I do now? And so the goal is not to chart search and point out bad things. It's to actually work in collaboration where there's time to make change and get to an accurate diagnosis in the most cost-effective and evidence-based way possible.
Great. Thank you for sharing that. It seems like, of course, in all professions, you have people who do things differently within their own practice. And I'm trying to decipher if the testimony that we're hearing today on behalf of the doctors, if that's common practice across the board, because I hear a lot from APRNs that their collaborating provider does not provide that support, and they're 75 miles away, and it's not a hallway consult because that person isn't physically located in their building. And really, that's just serving as something that's being done, on day 13 or day 14, and not truly providing the support that it seems like you and your colleague are doing a great job of providing. So thank you for answering my questions.
You're welcome.
Further questions? Representative Seitz.
Yes, to inquire.
Go ahead.
I'm looking at one of the handouts that was passed out. It's entitled Patient Risk and Malpractice Concerns with Non-Physicians. And I'm going over some of the points. In point number 9, it states, many malpractice cases in primary care or family medicine were related to a nurse practitioner's failure to order a medical test or to obtain and address test results. And yet I heard earlier testimony from your predecessor that, and even some comments here, that too many tests were being given. This says too few tests were being given. Some of these negatives, and when I present a bill, if I'm favorable to it, if it's one of my bills, I'll type up a page and find all the positive quotes that I can find and the positive happenings. Could many of these negative instances that could be applied to APRNs also be applied to physicians? If you dug deep enough, you could find malpractice and things like that involved with physicians as well. Is that the case?
I agree. In the current way that the medical system is set up, physicians are able to hold each other accountable and answer to the Board of Healing Arts. And so under the proposed legislation, that even though they would be providing and being able to order similar tests, and I think what they were getting at this is sometimes not knowing what to do with the test results is a problem. There's kind of a decision paralysis regarding what to do with that after. How do we hold APRNs accountable if they're not under the same regulatory body that physicians are who are ordering the same test?
I understand. Could that also be applied to physicians as well? Holding them to a certain standard through misdiagnosis or something like that. I'm looking and reviewing these, and I think they could also be applied to other members in the field.
Sure. And I think that is where we do hold each other accountable as physicians. And so it seems peculiar to me that if they are wanting to order the same test and prescribe similar medicines, why would they not be held to the same standards that physicians are?
Okay, thank you.
Further questions? If not, thank you very much. And for those of you who aren't familiar, she and her husband are at Bothwell, which is a unique rural medicine practice situation. And she's very passionate about that field. So that's not a pro or con. I'm just saying if you haven't studied that certain unit, you might want to talk to how they work it. Let's see. We are down to a con.